Good evening, everyone. My name is Kristen Williams, and I'm a fourth-year medical student at the Albert Einstein College of Medicine, and I'm the SNMA Region 9 Director. And I am so excited to be with you all tonight and to welcome you to the start of the specialty series for transplant medicine. This series is a part of our Sowing Seeds program created by our national president, Asase Obo, in collaboration with the Alumni and Multicultural Affairs National Committee. Throughout this year-long program, we'll provide resources on how to succeed as a pre-med and medical student, and we'll touch on everything from financial literacy to preparing for board exams and more. So make sure you are a national member by visiting the snma.org and signing up to stay in the know. Lastly, I just want to make you all aware that tonight's episode goes along with our community service protocol for the month of September, which is tissue and organ donation, education, and recruitment. So all month, our community service programming will focus on educating underrepresented communities about organ donation and encouraging people to enroll in organ and tissue donation programs. So tonight, we have four amazing and inspiring panelists who are excited to talk to you and answer all of your questions. So first up, I will introduce Dr. Velma Scantilbury. Yes. So Dr. Scantilbury is a transplant surgeon at the Christiana Care Kidney Transplant Program. Next, we have Dr. Silas Norman, who is a nephrologist specializing in transplantation at the University of Michigan Medical School. Next, we have Dr. Vaughn Whitaker, who is a transplant surgeon at the Westchester Medical Center. And last but not least, we have Dr. Latifa Silsky, a transplant surgeon in liver transplant, kidney and liver transplant at UC Health Cincinnati. So let's jump right into it. If we can start, we'll have Dr. Scantilbury just tell us a little bit about your story. Where you trained for medical school, how did you choose transplant medicine? Did you have mentors in the field? And end with your favorite thing about the field.
Oh, thank you so much. It's a wonderful opportunity for me to be here with the SNMA students and staff, just sort of talking about my career. I am a transplant surgeon. I have to say that my career started when I was a resident or medical student when I met Dr. Barbara Barlow, and she was a pediatric surgeon, and I wanted to be just like her. She was at Harlem Hospital in Brooklyn. In Manhattan, really. And so in my quest to be a pediatric surgeon, I did transplantation research, fell in love with it, been out to University of Pittsburgh, did a fellowship in transplantation surgery, multi-organ transplantation surgery, doing livers and kidneys. And so that has been my career mostly until the latter half of my career, where I was specializing in kidney transplants, particularly. So I have been doing this for a very long time, over 30 years, and I'm excited to be here with you. I really enjoy what I do. I particularly like the idea of making people better, saving lives, the whole, for me, organ donation and the drive to get more people willing to be organ donors continue to be my quest, to increase the numbers of those willing to sign the organ donor card. And if we can just do that, and each one of us encourage someone else to be an organ donor, we can continue to save many lives. As over 20 people die each day waiting for an organ. So I work at Christiana Care in Newark, Delaware right now, doing kidney transplantations, primarily with a little bit of general surgery, and coming to the close of my career. So thank you for having me.
Thank you so much. Dr. Norman?
Good evening, everyone. Very happy to be here with you this evening and spend some time talking about transplant. I am originally a native of Detroit, Michigan. I did medical school at Wayne State University. Was down in Houston at Baylor University for my residency, and it was during that residency that I met a gentleman, Dr. Wadi Suki, who's a nephrologist who turned out to be a great role model and the kind of person that makes you want to go into a field. I'd already decided I wanted to come back, help the community, particularly folks with diabetes and high blood pressure. Dr. Suki helped direct me into nephrology, and then I came back to the University of Michigan for my fellowship, where I was fortunate to meet my research mentor, Dr. Kinlulu Ojo, who really guided me into transplant. Transplant is a fantastically rewarding field. As Dr. Scantilbury said, we have an opportunity to really transform lives. A lot of great patient care. We have an opportunity to really help close some of the gaps and disparities in healthcare. And I very much enjoy the opportunity to help educate patients and help them become better advocates for their own health. So very happy to be here.
Awesome. Thank you so much. I just want to encourage all the people tuning in to please comment and ask questions to our panelists. You can place them now and we will read them out after we finish introducing everyone. So next up, we can have Dr. Whitaker introduce himself. Oh, you are on mute. Uh-oh.
Hi, my name is Vaughn Whitaker, and transgen, doing kidneys primarily. I was trained in transplantation at the University of the West, in medicine at the University of the West Indies, Mona in Kingston, and then came to the United States, where I continued my training in general surgery at the Harlem Hospital, where I did a rotation in transplantation at the Columbia University Medical Center, where I met some of the luminaries in transplant, including Lloyd Ratner and Joy Mond. And over a period of 3 months, really, they spoke about transplant with such enthusiasm and encouragement. And like Dr. Scantilbury, I also wanted to be a pediatric surgeon. But as I discussed transplantation and pediatric related research with these transplant surgeons, it became I became enthralled with it, and eventually an opportunity opened up, and I was able to train at Columbia. And now I am doing kidney transplantation. It is highly rewarding to do transplantation. I just did a transplant case last week, and the patient was a 52-year-old man, and it's funny, he's been on dialysis for the last 10 years, and his brother also for 20 years was on dialysis and never got transplanted. And he got a kidney transplant. And the first few days was pretty rough, but we're able to get him through. And by day 4, he was making good volumes of urine, and his creatinine began to come down, and all the pain started to subside, and his blood pressure started to be better, and what have you. And, you know, I went to see him in the morning, and he was crying, and you know, he was just saying, "Thank you, doc, because you and your team were able to change my life. You were able to give me something that I've been dreaming about all this time, to be able to pee, to be able to not be on dialysis." And when he thought about his brother not having the chance that he has, he was so grateful. And that, you know, in essence, is one of the wonderful things about transplant, the ability to change the trajectory of someone's life and to bring normality to their lives and to make them feel fulfilled. And incidentally, his birthday was on the 12th, so he celebrated his birthday in a hospital, and I can't think of a better birthday gift for this gentleman, as to being free from dialysis for the last 10 years.
And I wanted to add, for those of you in the audience who think that us as professionals, you know, talking about the words P, it's pretty normal professional world in the world of transplant. When we ask our patients, have you peed today? So don't be flabbergasted by us talking about that. It's a common word. And I also wanted to add, I forgot in my quest to answer my question, we do have something in common with Vaughn. I did my general surgery at Harlem Hospital after completing my medical school at Columbia University, and was introduced to transplantation earlier than he was at Columbia University in the transplant department with Dr. Mark Hardy, and that's how I got started.
All right, thanks, guys. And last, but certainly not least, we'll have Dr. Silsky introduce herself.
Hi, everyone. I am very privileged to be here, especially with this group. It's one of the times when you're like, wow, I know everybody here at different stages of my life. So it's one of those things where like, oh yeah, actually, that is actually correct this time. For me, I came through transplant. For me, the transition happened in medical school. I was a slightly older student, so I had done a lot of research. I was in the orthopedic lab. So when I was first 2 years of medical school, I decided to be an anesthesia tech. So while I was doing that, I was able to get to see all kinds of surgeries and fell in love with transplant, watching Dr. Sanaday, who was probably the most humblest person I had ever met as far as that went. And the whole multidisciplinary part where they were just kind of connecting with the anesthesiologist and having this magical connection, and essentially got this liver through without any blood products. And it was just amazing to see this organ that was pale and not functioning and bring somebody a second chance at life. But it really was solidified when I was, so I did a sub-I. I was at University of Michigan, and Kristen Gooden, who was a fellow at that time, and she was inspirational. She also had kids, and I knew I wanted to have kids. And she was always singing in the hallway. I'm like, oh, somebody who also sings in the hallways. So you can be a surgeon and sing in the hallways, and you're going to be okay. And for me, the transplant is essentially the epitome of multidisciplinary care. I think there's other places that do it, but when you truly are rounding with a nephrologist and a pharmacist and a social worker, and everybody gets to say, or then the dietitian makes eyes at you because you are not paying attention to their how much PO intake they really took in. It really comes to bear that here we have a chance, we get a second opportunity to help somebody get to a normal life. Somewhere else, a person has gone through an extraordinary, horrible tragedy. And while the people that were taking care of that patient couldn't save their life, they were able to at least save another person's life that they will never know and never see. So transplant to me is like the utmost of sorrow, but from the sorrow you can get these amazing joys, and through this joy you get all these people that come together and work together to kind of help a patient through. So transplant is it's an honor that I get to do that, and I'm hoping I can do that for a very, very long time. Thank you.
Thank you all. Those are all really inspiring introductions already. So I'm excited for us to get into some of these questions. The first question that I have is, as we think about transplant surgery in, Black and other minority communities, what barriers exist in the realm of like recipient donor and like hospital administration for marginalized communities?
I think there's so many barriers. We could spend all night talking about barriers. There are barriers on either end. There's institutional racism in terms of looking at how patients are denied access to care, in terms of the social inequities that are out there. But as far as when we think about patients, if you think about the fact that as African Americans, we make up 13% of the population, 12.5, and we are represented on dialysis in many inner cities as much as 40%. Nationally, there's 35%. But in places like Mississippi and in the South, then you can be as high as 50 or 60% of the waiting list waiting for a kidney transplant. So there are disparities when it comes to just in terms of the disease population, high blood pressure and diabetes being the number 2, 1 and 2 causes, 2 and 1, diabetes number 1, and followed by hypertension, that we see so predominantly within the African American community. And so we have those issues that we have to deal with, and we have the many issues of, in terms of, yes, we are disproportionately affected. We don't donate, so in terms of getting the number of people on the waiting list, getting them kidneys, trying to get our African Americans to think about not just deceased donors, but living donors. I'm going to talk about that part in terms of encouraging people to donate, because we will never be able to solve the issue of getting every person an organ, and only about 35,000 people get an organ per year, but yet still the waiting list is over 92,000 people on the kidney transplant list. So there's such disproportionate, with a third of those being African Americans, but we're not donating at the same rate. So getting to the transplant list, getting patients there on time was just some of the things that I would touch on, and I leave Dr. Silas and the others a chance to also talk about what they see also.
No, thank you. So, I echo those comments. I think the access to care is huge. There are delays in referral for transplant. There are clearly differences in who's deemed to be appropriate for transplant, which highlights both some professional and institutional bias on our part to get over. Dr. Scantilbury talked about the inadequate number of living kidney donors that we have for particularly our Black patients, but also some of our brown patients. And that too is a combination of willingness to donate, but also the excess medical disease we see in the African American population, where a number of people are not medically appropriate to donate. And then we see, for a number of reasons, often the transplant outcomes, at least in kidney transplant, are inferior for African American patients compared to at least our white patients. And that is not a biologic phenomenon, but it's really a combination of access to care, education. We can't underestimate the impact of financial resources that also impact our community. So there's a lot of, as Dr. Scantilbury said, across the board there are disparities, which I think is why it's so important that a panel like this, that this group is involved in transplantation, so we can help explore and close some of those barriers.
I think the referral part is probably the part that hurts my feelings the most. I was in clinic about 2 months ago, and a 37-year-old, otherwise super healthy lady had come to see me to get access planning. So that's when you get dialysis access. Had her vein mapping all done, and come to see me to see if I can put a fistula in her arm so she can start dialysis. And so I'm looking at her chart. I'm like, so, what's the status of your transplant referral? There's 4 places around here. Where have you gotten started, if any place, for your transplant referral? And she told me that she was told by one of the dialysis people that she should be on dialysis for at least 5 years prior to starting a referral. And that is, to me, astonishing. There are times when I just go onto websites in our regional area just to see, hey, what do they say about transplant? And in some places it'll say things like, even if you are a candidate, even if you have diabetes or hypertension, you might be a candidate. So there's a lot of systemic things that are there that that part is mind-boggling to me, that these things are happening and continue to happen. So now she stays on dialysis for like 5 years. Now she starts developing other complications. And now it's harder to get onto a transplant list. So I don't know how to fix that part, but the referral pattern is definitely impressive. And of course, sometimes you get pushback, like, why are you talking about transplant? Well, that's exactly why I do access. I do access so I can talk to people about transplant as well. And of course, I encourage them to talk to nephrologists, ask for a referral, etc. But people should be able to self-refer to kind of get out of the cycle of not getting on the list, or at least even getting a chance to get on the list. And that part to me is just heartbreaking.
Yeah, and that is so true, because one of the things that we try to get across is that patients can refer themselves. And I used to really push that when there's a period of time where I worked in the South. And then it got to the point where in some of the hospitals in the South, you could not go to a transplant center unless you were referred by the nephrologist. And the nephrologist had to clear your referral before the surgeons would see you. And so that limited so many patients who would come to me and say, well, even after I moved, can I come to Delaware with you? Because my nephrologist refused to refer me to the transplant center, even though I have a living donor. So, and then the part of the other fallacy, and patients are told that that they first need to go on dialysis, or they may need to stay on dialysis for the rest of their life, or you have to be on dialysis before you get to transplant, which is not correct. And I think getting correct information out there and educating our communities is very important to get this information to our patient population.
It's actually pretty shocking, the data as it relates to transplantation in African Americans, and whether you're taking it from the referral stage to those who actually get to the wait list and those who actually get transplanted, the outcomes are nowhere near the majority communities. And so, there's a national reckoning that we need to make. And I think this is where having the voices of African Americans is so important. I've been in transplant for only 10 years, but I've been in so many what we call selection meetings, which is where we decide whether or not a patient is appropriate to be placed on a transplant list. And it's amazing that sometimes a recipient, a potential recipient, someone who potentially may need a transplant, it's amazing sometimes the reasons why they may be denied being put on the list. Either the social worker or one of the coordinators or didn't think that the social situation was solid enough, or there's report of a big one is non-compliance. And what I would notice in these patterns of conversation would be a lot of those conversations would be had about African American patients. And it would amaze me that sometimes you'd have a relatively healthy African American patients who would be denied access to the transplant list, compared to someone who is non-African American, who has multiple comorbidities and would be listed. So and if you don't have a mass of people who are sensitive to these discussions and are recognizing that this is happening, it will just continue to happen. So, we need more social workers who are African Americans. We need more coordinators who are African Americans. We need more nephrologists who are African Americans. We need the whole spectrum that can appropriately and adequately represent the experience, the African American experience. We understand the patients better. We know what they are going through. We know what their struggles are. And I think because we do know, we're more sympathetic and we can advocate for these patients in a more meaningful way. One of the things about being in a transplant is that you have to be an advocate for your patient from the very beginning to the point where they're transplanted and they need to take care of their graft. Still, they will need to have an advocate, encouraging them to make sure they're keeping up with taking their immunosuppressive regimen, making sure they're exercising, making sure they are controlling their diabetes, controlling their hypertension, making sure they're checking their skin of the sun. All these things has to continue to happen. And as African American physicians and providers and social workers and nutritionists, I think by having that sensitivity and that experience will help us to better manage these patients and help them have better outcome across the transplant continuum.
Awesome. Thank you guys so much for those great answers. I know we have some questions from the audience. Okay. So this first question, hi all, thank you for participating in this panel. How do you strike a healthy work-life balance given the unpredictable nature of transplant surgery and medicine?
You know, I mean, I am home for dinner by 5 o'clock most evenings. Transplant is a field where there is what we call feast or famine. There are sometimes when in a week you'll be getting many transplants, and your family won't probably see too much of you, or you won't have too much time to be doing what we call, you know, recreational stuff. And then there's another time when there's not much going on. And it's a regular day. It's a 9 to 5 or 8 to 4 day. And you get to go home and you get your weekends off and you get to do whatever you are interested in, whether it's driving in the country or playing golf or just hanging out with your kids if you have a family, or going to a concert. I mean, there are not too many of those right now with this pandemic. But I find that being a transplant surgeon has actually been quite rewarding, and you know, you have to be flexible, meaning that, you know, while you are on the clock, when you're on call, you have to be willing to not make any firm plans. So if your birthday or someone's birthday who you care for falls on a call schedule, there is a chance that may be disrupted. In that case, you probably should plan not to be on call if it's your wife's birthday or your significant other's birthday or your kid's birthday. But it does happen, and you know, your loved one will need to
Vaughn,
understand.
I don't know what program you're in, but I want a job in your program, being home by 5 o'clock. Okay, I'm going to put in my application. I'm coming over there.
I'm coming too.
he has the cushy program. In most of my career, I don't think I made it home before 8 or 9 o'clock. So my hat's off to you, Vaughn. You're in a program that I aspire to be. But mostly, I think for many of us, for me at least, as far as kidney transplants, it's kind of those that are scheduled as far as living donors. But as far as for me, deceased donors, it's generally at night. That's when I could get in the OR. That's when the OR schedule lets up. And even in my training, when I had young kids, I was so programmed to just go home, get them to bed, and leave about 10, 11, knowing that with the change of shift, I wasn't starting anything till midnight. I get finished by 5 or 6 o'clock in the morning and get back home to get them back to school. So I became the queen of night surgery pretty much because that's how it fall, and it correlated with my day life in terms of being able to be a mother and balance that kind of schedule. So even as my kids grew up and left home, it was still a struggle to make it home early. And I have, part of that was that most of my career has only with either being on every other night or 3 people, mostly just 2. So it was a little bit more hectic, but I was still able to manage being a wife and a mother. And, my kids say, they got denied some stuff like, going to Girl Scouts and didn't take them to certain games, but, they turn out okay.
I'll add to that, but I'll give you a tip. In general, it really depends on how many partners you have.
Yes.
So you can have, and that can be the same for medicine too. So you can't base it just on that. You could be a community a practitioner. You can be a hospitalist who's on every other night.
Yeah.
So your schedule really depends on how many partners you have and how much, when you're going through, you want to look through and say, hey, what kind of practice do I want? You can have a practice where you don't have to work that much, and you can have a practice where you're the same person who's doing it every other day.
Right.
But really, what I would really challenge you, because for me, from my perspective anyway, there are other people and more than thousands of people who work 2 or 3 jobs. So they work the same kind of hours that we work and don't get that kind of recognition and don't get the kind of pay that they can actually send their kid to whatever school that they want. So from the way I see it, yes, my schedule is unpredictable, but I get to do the things that I want to do. And that is a blessing that is not necessarily afforded to everybody. So, and on the other side, from a child's perspective, I mean, I could be, in a bus taking a 3-hour ride every day and miss her things that way as well. Your children are children. They love you no matter what. I mean, if you go through medicine, you'll see children who are in terribly abusive situations. You try to take that kid away, the kid's like, wait, this is my every person. This is my everything. Why are you doing this to me? So those are the 2 things I'd point out. My daughter, of course, is going to be like, oh, why are you leaving? But if I had a 9-to-5 job, would she be like, I'll see you at 4? No, it's not going to be. No matter what, your kid's going to want you more than you're able to do. But the privilege that I have, yes, I came home today at 6:30. Yeah, I had ordered food in, and I'm going to, as when I get off this call, go back to the hospital to do a donor. And then I have a full day tomorrow of cases in clinic. And you just do what you need to do. Again, the nighttime surgery and that kind of benefit, I can put her to bed, work all day, come back, put her to bed. So you can kind of arrange it a little bit. You have a little bit of ability to kind of arrange it so that you can prioritize whatever you would like to prioritize. But I have hospitalist friends that have a crazy schedule. You can make it however you need to, depending on what you want. But that's my 2 cents on that. I'm sorry if I took too much time there.
No, so yeah, I'll just jump in and add that I start to laugh a little bit at the question. I think we get busy. I think, I told my son that there's kind of 3 levels of work that you can do. You can have a job, you can have a career, and you can have a calling. And I think when you do transplant, it's a calling. It's, it's not what you do, it's who you are, kind of 24/7. And we love what we do, and the hours are long, and it can be difficult sometimes. You're tired, but we're really transforming lives. And I think you just try to make a point to be 100% on when you're at work, and then do your best when you get home to be 100% there, which doesn't always work. And after a while, your spouse will stop looking at you funny when you get paged at 10 o'clock. And kids are helpful because they have soccer games and things that make you have to arrange your schedule a little bit around them. But it's rewarding. And at the end of the day, I think as Latifah said, there are worse things you could be doing. We're really, privileged to be doing this. And I think at least, my boys, they see the work you do and the good you do. And I hope when you grow up, that ends up, helping them make a positive contribution, to the community as well.
Definitely work-life balance and, trying to balance what's really rewarding to you in your career are such important things for us as future physicians, no matter what field we're going into. So along the same work-life balance question, what advice would the panel give to the spouse of a doctor?
I would say that you first have to trust them in their time away from home. My husband used to always joke about, I don't know whether you're out having an affair or not, because all these nights at work, I have to. So I'm just throwing out there. Definitely has to be a trust element, and you have to have you have to have your own source of gratification, and things do make you happy and not depend on that person. to make you happy, because you're going to spend a lot of time alone. So you have to really have your own career and your own life, and be able to say you're going to give a whole lot up on the time that you have together with your spouse. You got to make the best of it. That's my advice.
Same hobbies. I mean, my husband has this amazing microphone, one of, I think, 6 now. He calls people. He does these little like mini in-home podcast things. So you have to have a hobby. I think that helps a lot if you have something that is completely engrossing. And he changes his hobby. Right now, this is the newest. This is a COVID hobby that he has. But having a hobby definitely helps.
Yeah, I mean, I think the advice I would give to a spouse is to communicate, be willing to engage and communicate and understand. You know, early on in my marriage, I mean, my wife was, I made a mistake once of, at the beginning, I only had one car. We had only one car. And I thought I was just going to the hospital for a quick, just running up to the OR just to see something. So I said, just give me a few minutes, as she waited in the car. And I know you're laughing because you know exactly what happened. I mean, 3 hours later, I went downstairs and that woman was fuming. And she said, "Never again will I listen to you about coming to the hospital and waiting." So she never comes to the hospital with me anymore like that. But now she drives by herself. Then she didn't know how to drive. Just learned how to drive. But you have to communicate, and you learn, and you give and take. You give and take. I mean, the schedule I plan this. Of partners, you can't necessarily get all the days off that you want, or all the days on that you want, but you discuss it with your partner, your spouse, and so that she has some say, so she feels like she's a part of the process. I think by having that, and again, today I got my schedule, I sent a copy to my wife, and she's like, I didn't like that day, or didn't like that day, but at least some of the days that she said she wanted me off are included. And she's not 100% happy, but she's 85% happy, which is decent, I would say. And you just have to communicate, and it's a give and take, and lots of understanding. Yeah, that's what I would say. That's the advice I would give to any spouse.
Plan your vacations well, I would say, and make sure that I live from vacation to vacation. When you have time off, leave town. Don't hang around. Otherwise, somebody's going to call you in, and you'll end up working. So either drive away or get a ticket. Silas, sorry, I cut you off.
No, that's perfect. That's absolutely true. You cannot stay in town. I would just reinforce. I think it's the communication that's key. I also have taken to, my wife has a copy of the schedule and my calendar, because early on when we were married, I had this habit, you're busy, I had this habit of, it would be, 4:30, and I would say, oh, you know what, I have a meeting at 6, and run off, and then you're just in the doghouse. And then I think over time, balancing that home. So making sure when you're really busy, that then when I'm at home and not busy, that you take an active role with taking care of the kids, because, it's one thing you were gone, but then you can't come home tired and also not be taking care of the kids. And then I think over time, again, because you're living this, I think for me, at least over time, as we attended some of these transplant related charity functions and so forth, and I think as your spouse gets to see what you really do, and they get to meet your partners, and they meet and sometimes some of the patients you've taken care of, and really helps put it in context that you're not just out there, fooling around. I think it gives them a better understanding of kind of the importance of what you do, and helps you kind of balance out, your responsibilities at home with what you need to do for your patients.
And sometimes you're sort of forced to have to attend the social events surrounding your department and division parties and show your face. And if you happen to be the only African American, you stick out like a sore thumb. And oftentimes my husband would be saying, I'm not going. And so after a while, sometimes you say, are you really married or are you just pretending you are? So,
Oh,
but
God.
just a little humor there.
Yeah.
Thank you. That's helpful for me to know about. So we have another question. So what is your opinion on inclusion of patient education on organ donation as a component of an initial primary care visit and encouraging organizations such as the AOA and AMA to support this addition to the average visit?
That's an excellent point and suggestion. And in fact, the primary visit, as you are all aware in the audience, is getting tighter and tighter and tighter. And the primary care physician is having less time to do more in terms of educating the patient population, preventative health care, mental health screening, screening for chronic diseases, diabetes, hypertension, and of course donation. But it's definitely well worth it, and it's something that probably should be encouraged as a part of the a reimbursement system whereby is organ donation discussed. You could get an extra $5 on your reimbursement, and that would go a far way in encouraging donation. So certainly, I would support such an idea, and I think it's a useful step in overcoming some of the disparities and some of the low rates of donation we see.
I think you touched on a key point. I think one of the key points is that the way our current payment structure works, I think, throughout medical school, I think I was one of those people that they kept doing those personality things. And they're like, oh, you're such a family medicine person. I thank you. But one of the big challenges of being a primary care person is what you were talking about. Right now, the system kind of penalizes you for going over your 15 minutes. I'm one of those people who are chronically over my allotted time per patient. And I'm only dealing with maybe just access and transplant or just transplant. So if you're trying to get somebody to be able to even just take their I was one of those people who didn't take my asthma medications until a physician, Black physician, sat down and actually explained the pathophysiology to me a little bit. And I was like, oh, that's why I should take my chronic steroid. And then I started taking my medication. So now to put that additional thing on them without actually changing the pay structure and actually the penalization of like having to not go over your 15 minutes would be the way to do it if it was possible. So it would have to be that we would prioritize primary care in such a way that doesn't actually mandate that they have to actually decrease X amount of people's blood pressure by X amount of thing without actually increasing the amount of time that they're talking about each problem. So I would not want to give them another burden to take on, like, hey, also, in addition to you trying to talk about the pathophysiology of all these drugs and have them try to get to be non-compliant because we've labeled this person and now their whole health system is going to be like not taking care of them correctly. Personal bias against the word non-compliance, but and all the things that go with it. But it would have to come from a place of like, how do we give primary care the space and breadth that they need, that they can actually address these issues? And maybe, when I talk to the medical students, I'm like, hey, make me obsolete. If we can cure diabetes and hypertension and not have the end stage thing, then that would be one way of getting rid of the list, because now there's nobody that's going on. Yes, there's going to be a certain amount of people, but that would help. That would be amazing if we could just do the great thing up front. then I would be not needed, and that would be good. You know, being not needed is good, but I'm here, and we're here, and we work that much because despite the amount of people who are on the list, we're transplanting and we're working pretty hard. But that would be amazing if that was possible. But that's all I'm going to add to that.
Certainly, one of the things with registering as organ donors is as much as we live it every day, a lot of people just don't understand the need or don't know about the need. And despite the really epidemic levels of disease in the community, many people are just unaware of the need. And so whether it's in a primary care physician's office or at various venues in the community, I think it's more and more education. We did some interesting work with the National Kidney Foundation in Michigan a few years back, where we engaged some of the graduate chapters of some of the Black sororities, and they took on registration just as their thing to do for the year. So, but even within, this well-educated, professional group who took this on as just a good thing to do, once they got into the project and educated themselves more about organ donation, what they found was, within their own chapters, there were people on dialysis. Within their own chapters, there were people on the waiting list. Within their own chapters, there were people who had been transplanted. And so many people just didn't realize the extent. And so I think if it can work in the PCP's office, that's good. But I think broadly to meet this demand in the absence of every venue we can use to better educate people, I think.
Yeah, I think the private physician's office are hard pressed to get all the information into patients when you think about the majority of people, patients, either trying to get them to take their blood pressure medicines or talk about diabetes or heart disease as those becoming the dominant issues in terms of healthcare. And then adding it. So it's really about coming up with ways to get that information across, perhaps even adding it to videos in the waiting rooms or challenges of how do you get this information to the community when it's not on their radar and not once a year or twice a year that we normally talk about organ donation or transplantation, but really to address the need at these national meetings across the board. So it is an issue of education, and it's one of the things that we constantly have to make sure that we're doing.
Definitely. But someone going into primary care, education is very important to me. And I think that it's definitely super important for us to focus on educating, particularly our patients of color, about this issue and why it's important. So our next question is, what is your opinion on opt-out rather than opt-in organ donation system? Probably particularly here in the United States.
Well, unfortunately, I haven't been in transplant so long. We've tackled this problem in terms of how do we increase the amount of available organs out there. And, England has just gone to the opt-in system where everyone is otherwise you have to come up with a reason why you're not going to be an organ donor. And in this country, you have the constant talk about, it's a democracy and we all have a right to make our choice. And so it's hard to get folks on board to be able to say that organ donation should occur unless you're really objecting to it. And that indeed may hopefully come about, but there's still a lot of work that needs to be done and coming up with a unified agreement as far as the population to even increase organ donation. Years ago, the Surgeon General was aiming for 85% consent rate at hospitals. And in some, here in our own state in Delaware, we are about 60%, but for many people in other states, Pennsylvania may still be 45%. And so we can't seem to be able to increase that overall organ donation rate above 50%, even in terms of even trying to get to 75%. So we still have a lot of work to do.
I think one of the big areas of work that needs to be done is actually in reestablishing trust. I mean, there's been too many communities and too many stories and too much history of abuses to have an opt-out system without addressing those things. Meaning that we'd have to reestablish that trust, that no matter what you come in with, the first goal is always to save your life, no matter what, no matter at all costs, put all the resources in. But if the community doesn't think that that's a possibility, and that that their organs can just be taken when they're still alive and given to somebody, that part we have to, that's where the education needs to happen. And that's where the trust part has to be reestablished from our side, to say, hey, this is what the medical profession does. What does brain dead testing mean? What does donation after cardiac death mean? And until we really have a reckoning of all the medical based abuses that have happened on a racial level, then I think it's hard to say, hey, if you have to tell us that you don't want to donate. I think that is going to be key. And just I mentioned this recently, the SNL skit with Tom Hanks about Black Jeopardy. And then on the other side, there's a population that does have that thing, that this is my body, my right. I don't trust the government, or I just don't trust doctors. So there's two areas that are, separated a lot, have some commonalities in that there's no trust established with the medicine and with the government. If you have an opt-out system, you have to fix those problems first. And yeah. It's a long conversation, and you could have a whole hour on opt-in, opt-out, and how you could potentially try to make a difference there. But I don't see it happening anytime soon right now.
Yeah, Americans don't like being told what to do. I think we can look at what's going on with masks in this country and see that just because you tell somebody a good idea, there's going to be a cohort of people who push against it. I absolutely agree with what's being said. And I think it's really educating people about the need so that they make a decision. And I think it really highlights why we need many more of you going into medicine, because they need to see more people like us as a bridge to that trust in medicine, in the institution, to trust that we're going to take care of people appropriately. And that we're being transparent, I think, is the way that we're going to really increase donation, among other things.
Yeah, I think that's really important, because even for our current generation, they have a better understanding of the issues that we're facing. While our parents may not agree to organ donation, it may be hard to sway them from that standpoint, because there's still that distrust of the medical profession. And even in today, just talking to one of the techs in the eye doctor's office, and she said her parents were very upset with her when she agreed to be an organ donor because of that same reason. So I think we have a lot of education to do. And you guys as the next generation coming after us, really, it becomes important to really sow those seeds and begin to educate and be cognizant of the need, the disparities, and get right in there and help resolve some of these issues, and be advocates for your patients.
I agree with the comments of all panelists, while recognizing that an opt-out system would potentially lead to increase donation. There's a lot of work that needs to be done in creating a sense of trust, a sense of confidence, especially among us African Americans and minorities, that there's a certain level of confidence in the system. And I believe in the system. I believe that currently the practices are there, but there's still a gap between what we actually do and what people think we do. So that gap needs to be bridged.
Definitely. Trust is a big thing, and that's something that we definitely have to combat as physicians, and hopefully as we have more African American physicians, it's something that we can work towards. So next question we have is, what would the panel say is the most rewarding part of their roles?
For me, it's the patient. It's the patient interaction. It's knowing that you have made a difference in someone's life. That's That's the most rewarding part. And then, having a team of people who have taken part in that, owning that and feeling really good and really satisfied about that. And transplantation affords you that. I even all the members of my team, my coordinators, my nephrologists, were really happy, celebrating. We were discharging no patient, and we were really celebrating how we were able to get him through the initially difficult early days, and now he's really like a rock star. And that is super satisfying. There's no feeling like that, and that is probably one of the most rewarding part of my job.
Yeah, I would have to have to say we would all likely agree that the difference that we make in the lives of our patients is tremendous. I have to be thankful that God has blessed me with this gift of having the skill to be able to help others. And I was doing a webinar just a few days ago, and one of my patients who received a transplant, probably likely a liver transplant, almost 22 years ago, and she came on to thank me for having done her transplant. And those things are so rewarding, just sort of being able to see the difference in the lives of people who you've been able to touch. But on the other hand, knowing that we also have to be grateful and give kudos to all the donor families who were willing to say yes to organ donation, because they were willing in the moment of pain and death of their loved one, being able to save someone else's life. And I never let my patients forget it. It's constantly, have you written your donor family? Before you think about not taking this medicine, think about the family and the life that was given to be able to give you another chance, another gift. This gift, remember it, take care of it. So I think it's really something that they should treasure, and I certainly I'm grateful for the opportunity to play a role.
I would echo, it's the patients. At this point in my career, I've had the opportunity to take care of people for, 15, 17, 19 years, and see people, come through college and get married and have children or have grandchildren. And half of our visits now, are, 15 minutes of a social visit and 5 minutes of medicine. And and it's really tremendous. I mean, just to be able to look back and, some of my patients will joke that, we both had hair when we started, working together. But it's just tremendously rewarding, being able to see people through that longitude course. And it's really, reaffirming as you go in every day to take care of folks.
Okay, guys, we have one more question before we wrap up. I know we're almost over time. If you keep the answer really short to this one, we'd love to hear your thoughts. What is one thing you think patients might not currently understand about organ donation and transplants that you would like to share with them?
I would like patients to understand that there's this waiting list, and when they're called to say, "Where's my kidney?" that we are not actually keeping kidneys in the refrigerator for them to be doled out, but that someone actually has to die, and families have to understand that that gift has to be given to get to receive an organ, and that through death there's life. So that yes, we understand that you're waiting years, and that we're doing all that we need to do to get you that organ and to save your life.
Yeah, the one thing I want my patients to know is that you have the power to make a great difference, whether you're a donor or you're a recipient in your own outcome. You have the power and the ability to make a huge outcome. And a patient who takes care of their organ actually is helping to keep their organ longer, and so they're not needing a second organ very soon. So that helps as well. And of course, if they donate, that helps tremendously as well.
I think the one thing I'd like people to know is that living donors actually get a great amount of joy and pleasure from donating. And I totally understand why you would not want to ask. I have a really hard time saying, yes, I would love a cup of coffee. Can you grab that for me? Oh, can I have your kidney? But putting it out in more of a general sense, to find those altruistic donors for themselves and to encourage the family members to actually ask for them to other people, not just say, hey, sister, can you give me a kidney? But hey, sister, can you put it on Facebook or Twitter or things like that? Because when we evaluate donors and donors who wanted to donate and were turned down, there's actually people who want to donate. So asking and having other people ask on your behalf is not something that's shameful. They should try their best that they can to actually find other people that are willing to kind of harass you, your friends and family for you on your behalf, because waiting on the list is suboptimal. And a living donor kidney will last them a longer time. And then they can say, oh, my surgery's at 7 a.m. Why have we haven't started yet? But that would be the one thing. Living donation and pursuit of living donation is a pursuit that actually also makes a donor feel good as well.
Agreed.
I would just briefly mention that, the most common reason that families in the hospital will elect to not donate their loved one's organs is because the loved one didn't make it clear their intent to be an organ donor at the time of their death. And so would encourage everybody both to register as organ donors and to talk with their families and make clear their intent that if something happens to them, they would like to donate. It would make a huge difference.
Okay, those are great pieces of advice. All right, last question. If given the chance to go back in time, would you go on this journey again? And if so, what would you tell your younger selves?
Yeah, I would go on this journey a second time. My younger self, I would tell, take it easy. Just take your time, just take your time.
I didn't have a plan B, so I would have to say I would have to take the same journey again, but I would tell myself to be bolder, be fiercer, and ask for more money.
Good advice.
Yeah, I absolutely do it again. Boy, in retrospect, I would try not to do everything and kind of pace yourself.
I always find this question challenging because I don't know if I knew what fellowship was going to be like, I'd be willing to do that again. But for me, the advice I told myself before, and I continue to tell, especially people who are slightly older or slightly non-traditional, is that life is happening all the time. You don't wait till you once I'm done, I'm going to start my life. You have to figure it out how to kind of weave it in every part of your life. And I would still continue to do that.
Well, awesome. Yeah. Sorry.
No, I was going to say, just enjoy life as it comes. Don't defer it till you're older or wait till you're retired, because you may not get there, or you may get there and not be in a great condition. So enjoy life as it comes along. It's a journey, and make the best of it and have fun. In terms of doing my fellowship over, you may have to give me some drugs to get me through the 2 years.
Well, thank you all again to our amazing panelists. We really appreciate your support of the SNMA and our membership. So thank you. This is a great conversation. I'm so happy to have been part of it. For those of you in the audience, thank you for tuning in to Sowing Seeds Transplant Medicine. Please scan the QR code on the screen. This will also be located in the chat to give us some feedback as we work to create useful programming for you. So thank you again for joining us. I encourage you all to follow us on Instagram at SNMA_official, on Twitter at SNMA, and like us on Facebook. But most importantly, if you are not a national member, please visit snma.org to sign up and get connected. Thanks for tuning in, and I look forward to seeing you at our upcoming Sowing Seeds webinars. The next one is on pathology on September 23rd. After that will be orthopedic surgery on September 30th and neurosurgery on October 7th.